Transcutaneous electrical nerve stimulation, or TENS, is any technique that passes electrical currents across the surface of the skin to activate underlying nerves. Technically, this could refer to lots of different kinds of electroanalgesic agents, but in this lecture I'm going to use the word TENS to describe currents generated by a standard TENS device, which consists of a battery-powered handheld stimulating unit that generates pulsed electrical currents. During TENS, pulsed electrical currents are delivered across the intact surface of the skin to activate underlying nerves. Users can adjust the pulse amplitude, the frequency, its width or duration, and the pattern of the currents to get the desired effect. We'll go through these parameters with some of our demo units in our practical class. One of the advantages of TENS is that patients are able to self-administer treatment and titrate dosage as they need it, because there's no potential for overdose and there are few side effects or drug interactions. Maximal analgesia is said to occur when TENS generates a strong but non-painful electrical paresthesia beneath the electrodes. Its effects are generally rapid, both in onset and offset, so patients are encouraged to administer TENS as needed and throughout the day. It's also cheap when compared to long-term drug therapy, and the devices can usually be purchased over the counter without medical prescription. It's important to note, though, that a practitioner experienced in the principles of TENS should supervise patients the first time they use the device to ensure that they are proficient at doing so. There are a couple of different methods or ways that TENS can be applied, but the intensities that would normally be used range from anywhere between 0 to 100 milliamps. The frequencies, or pulse rates, are usually anywhere between 4 and 250 Hz, and the pulse durations are limited to between 30 and 300 microseconds. Each method of applying TENS basically operates within those boundaries. Conventional TENS involves using low-intensity, high-frequency currents at the site of pain for however long is needed to produce strong but comfortable TENS paresthesia. Acupuncture-like TENS is where high-intensity, low-frequency currents are applied for between 15 and 30 minutes, usually over muscles, to produce strong but comfortable muscle contractions. Intense TENS is where high-intensity, high-frequency currents are applied for a few minutes at a time over nerves arriving from a painful site to produce maximum tolerable TENS paresthesia. Note that this nomenclature, conventional, acupuncture-like and intense, is a little misleading because it focuses on an arbitrary idea of the output currents and frequencies of the device rather than its physiological intention. But its use is widespread, so we'll stick with it. I'd also like to talk about what I would consider to be a fourth category of TENS, but which is often thought of as being a separate entity, called interferential or interferential therapy. Like classic TENS, interferential is used for pain relief, but operates outside of the boundary parameters I mentioned earlier. Instead of using the low-frequency currents typical of TENS, which are between 4 and 250 Hz, interferential relies on the principle of amplitude modulation, using two medium-frequency electrical currents, each around 4000 Hz, which summate or cancel each other out beneath the surface of the skin. These medium-frequency currents pass through the tissues simultaneously, and they are set up so that when their paths cross, they interfere with one another, and this gives rise to an interference or beat frequency, which has the characteristics of low-frequency stimulation. In effect, the interference mimics a low-frequency stimulation, but decreases the discomfort of stimulating deeper tissues, like muscle, when compared with classic TENS. Because nerves will gradually accommodate to a constant signal, what's known as a frequency sweep is also often used. The principle of the sweep is that the machine is set to automatically vary the effective stimulation frequency using either preset or user-set sweep ranges. Basically, the input frequencies, and therefore the beat frequency, are varied slightly within a suitable window so that the analgesic effect doesn't decrease over time. Now, whether we're talking about classic TENS or interferential, their proposed mechanism of action is based on the gate control theory of pain, in which modulation of a nociceptive stimulus to the brain occurs through its presynaptic inhibition in the dorsal horn of the spinal cord. Whether it's actually working for pain relief is the subject of contention, and I'll be discussing some of the research around TENS later, but it's important to note that TENS should not be administered to people who have implanted electronic medical devices, including pacemakers and defibrillators, and caution should also be taken before using TENS in those who are pregnant, have epilepsy, active malignancy, deep vein thrombosis, damaged skin, or who are frail. There are also several anatomical locations where TENS electrodes should not be applied: over the eyes, transcerebrally, on the front of the neck, through the chest, using anterior and posterior electrode positions, on broken skin areas, or over a tumour. But is TENS actually effective? Well, lots of patient populations experience pain, but most of the research that is being conducted using TENS for relieving chronic pain is in patients with fibromyalgia or cancer. However, even in these groups, the latest expert consensus would suggest that it has limited clinical effectiveness. Still, for patients with fibromyalgia and other localized myofascial conditions, a TENS treatment trial can be performed by a physiotherapist when pain limits therapeutic exercise performance, and its use can be continued when benefits are demonstrated. In other words, TENS may be useful as an adjunct to other treatments, but it should be recognized that any benefit is likely due to a placebo effect rather than any physiological, structural, or physical change in the patient's biological state. Research on TENS for pain relief has suffered from a lack of rigorous randomized controlled trials, and systematic reviews have found variable and inconclusive results for the efficacy of TENS in the management of chronic pain. Still, TENS is widely used in certain settings, and there are a number of case reports and uncontrolled studies suggesting that it may be effective, albeit with limited duration of benefit. The prevailing shortcomings in the field of research investigating electrophysical modalities are present here too. We just don't know the parameter-specific effects of this modality and whether, for example, certain dosage parameters may be more or less suitable for different injuries or impairments. For patients with cancer pain, 3 systematic reviews concluded that there was insufficient evidence to judge whether TENS should be used. Nevertheless, anecdotal evidence suggests that some patients with cancer-related pain benefit from TENS, and TENS is also included in the list of potential non-pharmacologic interventions for adult cancer pain in guidelines from the National Comprehensive Cancer Network. For patients with subacute and chronic low back pain, a meta-analysis of 9 trials comparing TENS with sham TENS, placebo, or pharmacologic therapy showed no improvement in lower back pain scores in the TENS group. There is also no convincing evidence from 3 trials that interferential therapy is effective for low back pain. For managing the pain associated with knee osteoarthritis, data are conflicting. A 2009 Cochrane review found that the evidence was inconclusive based on the poor methodological quality of most studies, which usually had small samples of participants and were very heterogeneous in their protocols. But in one large multi-center trial including 203 patients, no additional benefit was found for the outcomes of pain or function from either TENS, interferential currents, or shortwave diathermy compared with sham interventions. For non-radicular neck pain, a systematic review including 7 trials found no definitive conclusions could be drawn due to the heterogeneity in study interventions and measured outcomes. Even when the authors only included the 2 trials comparing TENS with placebo in their analysis, there was very low certainty evidence for similar short-term pain outcomes. Again, this is just a brief summary of the research, and new evidence may emerge. But generally speaking, it seems that any benefit associated with the use of TENS seems to be due to a placebo effect. Still, the possible benefit of that placebo should not be underestimated, particularly when it enables patients to progress to other forms of treatment. So that concludes this lecture on transcutaneous electrical nerve stimulation. To briefly recap, I started by discussing what TENS is, how it is applied, including the conventional acupuncture-like and intense methods. I also talked about the interferential variant of TENS, which uses medium frequency currents that summate with one another below the surface of the skin. I finished by discussing the evidence for each.